Good afternoon, everyone. My name is Aditya Shirali, and I'm a surgical endocrinology fellow at the University of Texas MD Anderson Cancer Center. Under the guidance of my mentor, Dr. Nancy Perrier, I will be discussing the evolution of the management and prognostication of parathyroid carcinoma. I have no conflicts of interest to disclose. I will start by briefly discussing the clinical presentation, molecular mechanisms, and management of the disease as it currently stands. Parathyroid carcinoma is a rare parathyroid neoplasm that accounts for less than 1% of all cases of primary hyperparathyroidism and approximately 0.005% of all cancers. The US has seen an increase in the incidence of PC, nearly 60% over a 16-year period, with similar trends being reported globally. The age of diagnosis is in the mid-40s and 50s, with a 1-to-1 ratio of women to men. Approximately 90 to 95% of parathyroid cancer is functional and results in moderate to severe hypercalcemia with a serum PTH 3 to 10 times above the upper limit of normal. Patients may develop prominent renal and skeletal manifestations. Patients may also present with a large parathyroid lesion and/or palpable mass. Patients with non-functional parathyroid carcinoma usually present late, with symptoms related to compression of adjacent structures. There are no reliable tools to help one recognize PC preoperatively. Surgeons must recognize the presence and extent of malignant parathyroid tissue intraoperatively. The surgeon must have a high index of suspicion based on metabolic features or imaging findings on ultrasound. Intraoperatively, parathyroid cancer may appear as a lobulated, gray-white, and firm mass with peritumoral inflammation or adherence to surrounding structures. Comprehensive genomic profiling through whole genome sequencing and gene expression analysis has allowed us to better understand both the genetic and epigenetic mechanisms involved in parathyroid cancer. Loss of function mutations of tumor suppressor genes, predominantly CTC73, represent the most common genetic alterations in both sporadic and hereditary syndromes. These alterations may be detected in up to 80% of sporadic and 75% of hereditary parathyroid cancer. The hereditary forms of parathyroid cancer are most commonly associated with germline mutations in CTC73. To a much rarer extent, it has been reported in patients with MEN1 and MEN2. The majority of CTC73 germline mutations are associated with hyperparathyroidism jaw tumor syndrome, or HPT-JT, which is a syndrome characterized by primary hyperparathyroidism with greater than 90% penetrance, ossifying fibromas of the mandible or maxilla, and tumors of the kidney and uterus. A recent series of 20 patients with HPT-JT found a 50% risk of parathyroid cancer with a high recurrence rate of 67%. Familial isolated hyperparathyroidism, MEN1 and MEN2, are all hereditary syndromes rarely associated with parathyroid cancer. Somatic mutations in CTC73 have been reported in up to 80% of sporadic parathyroid cancer. Importantly, 40% of the CTC73 mutations identified in patients with sporadic PC were found to be germline mutations, identifying HPT-JT in these patients and prompting screening for HPT-JT-associated tumors and familial testing. In addition to CTC73, which appears to be a major driver in parathyroid cancer, mutations in other genes involved in multiple pathways have been identified. Importantly, alterations in genes involved in the mTOR signaling and MAP kinase signaling have been identified and have implicated the PI3 kinase AKT mTOR pathway in the pathogenesis of advanced or metastatic parathyroid cancer. The management of parathyroid cancer is multifaceted and has evolved. We have seen a significant transformation of the field of systemic therapies with the use of more targeted approaches based on molecular profiles. Treatment of patients with parathyroid cancer is a collaborative effort. The diagnosis is one made pathologically and requires a high index of suspicion intraoperatively. Patients with primary hyperparathyroidism and a suspicion for parathyroid cancer should be treated at a center experienced with this rare disease. Surgery should be performed by a high-volume surgeon with expertise in parathyroid surgery. Postoperative surveillance and treatment of local regional recurrence or distant metastasis requires extensive collaboration between genetics, endocrinology, radiology, oncology, and pathology. If a firm mass with adherence to surrounding structures is encountered in the setting of hypercalcemia and high PTH, the gold standard approach is en bloc resection of the tumor, ipsilateral thyroid lobectomy, and resection of adjacent involved structures, including surrounding soft tissue, which may include central neck contents. However, both large database and single institution studies have found that positive lymph node status was not associated with disease-specific survival, and prophylactic central neck dissections are not recommended. The risk of recurrence in patients with parathyroid cancer exceeds 50%. In patients who develop local regional recurrence or localized distant metastatic disease, resection may result in prolonged period of biochemical cure. In a study of 31 patients with local regional recurrence, extended reoperative resections led to improved overall survival compared to those with less radical excision. The majority of patients with a hereditary predisposition for parathyroid cancer are those with HPT-JT with a CTC73 mutation. There is no role for prophylactic parathyroidectomy to prevent malignancy in these patients, given less than 20% of patients with HPT-JT may develop parathyroid cancer. Ultimately, over 90% of patients with this mutation will undergo parathyroidectomy due to the penetrance of primary hyperparathyroidism. When encountering a patient with HPT-JT, one must consider the presence of multi-gland disease. There are conflicting reports of the degree of multi-gland involvement. A recent study of 20 patients with HPT-JT found only a 5% risk of multi-gland disease, while an older study of 16 patients had a 31% risk of multi-gland involvement. While these two studies included families with different mutations, no genotype-phenotype correlation has been established in HPT-JT. As such, one must consider the presence of multi-gland involvement in patients with HPT-JT. The recommended approach is to perform a standard cervical exploration with resection of only abnormal appearing glands. If there is any suspicion of cancer, then en bloc resection should be performed as previously described. In addition, one may consider avoiding autografting of parathyroid tissue in these patients due to the risk of introducing potentially malignant tissue in an ectopic site. Patients with locally advanced or distant metastatic disease will require a combination of medical management of hypercalcemia and therapies limiting progression of advanced disease. Bone anti-resorptive therapies, most notably the monoclonal antibody denosumab, have been used in conjunction with calcimimetics to control hypercalcemia. Unfortunately, multimodality therapy in the form of chemotherapy and radiation have failed to demonstrate efficacy in patients with parathyroid cancer. Molecular profiling has paved the way for the use of targeted systemic therapies in the treatment of advanced disease. Tyrosine kinase inhibitors have shown efficacy in suppressing the angiogenic, proliferative, and bone resorptive signaling involved in tumorigenesis and hypercalcemia. Studies from several institutions have shown the use of cabozantinib, lenvatinib, sorafenib, and everolimus have led to the improvement in biochemical and radiographic disease. In patients with isolated distant metastases who are not candidates for surgery, IR-based procedures such as RFA or arterial chemoembolization have been used in the treatment of hepatic and lung metastases in 2 case reports. Recently, studies have been conducted examining the potential to use immunotherapy in the treatment of parathyroid cancer. A study by our group in 2018 showed that parathyroid carcinoma microenvironments had patterns of PD-L1 and tumor-infiltrating lymphocyte expression that may suggest benefit from immunotherapy. In 2019, Kang et al. Identified a subset of parathyroid cancer with high mutation burdens that may benefit from immunotherapy. 2 recently published case reports have shown that pembrolizumab was effective in decreasing both radiographic and biochemical disease in patients with metastatic disease, highlighting the importance of assessing tumor mutational burden and PD-L1 expression in these tumors. Single institutions with significant experience with parathyroid cancer and multi-institutional collaborations have allowed for studies examining the prognosis of patients with this rare disease. Parathyroid cancer has a variable course, notable for multiple recurrences, distant metastases, and intractable hypercalcemia. Mortality generally is due to intractable hypercalcemia rather than to direct tumor invasion and distant metastases. Survival rates have been reported as 77 to 85% at 5 years and 49 to 70% at 10 years. Level 1 evidence for survival in parathyroid cancer was published in the AJCC 8th edition, which noted that metastatic parathyroid cancer has significantly decreased survival compared to non-metastatic disease. Patients with distant metastases had a 16% 5-year survival compared to 87% in those without distant metastases. A recent study of 255 patients from Korea identified older age, parathyroidectomy as initial surgery, and reoperation to be independently associated with poor survival. Taken together, patients at risk for recurrence, namely those with inadequate initial operation, are at risk for disease progression with distant metastases, which significantly influences survival. Parathyroid cancer has a progressive course and is associated with high rates of relapse after initial surgery. Recurrence rates have been reported to range from 33 to 78%. The majority of progression occurs within the first 3 years after initial resection, both local regionally and to distant metastatic sites. Studies have identified multiple clinical and histopathologic factors to be related to a high risk of recurrence, including tumor size, vascular and soft tissue invasion, mitotic index, and Ki-67 index. In 2017, our group published work identifying a prognostic scoring system for recurrence-free survival. Multivariate analysis identified age greater than 65 years, serum calcium greater than 15, and vascular invasion to be negatively associated with recurrence-free survival. Patients with 0 variables had a 93% recurrence-free survival, while patients with 2 variables had a 27% recurrence-free survival. However, we must ask ourselves, in the era of molecular profiling and liquid biopsy, are there more patient-centered ways of predicting progression or recurrence? Liquid biopsies, particularly in the form of circulating tumor cells and circulating tumor DNA, are rapidly emerging as an important adjunct to standard tumor biopsies, aiding cancer detection and monitoring. It is thought that circulating tumor DNA is released into the bloodstream through apoptosis or necrosis. The fraction of ctDNA tends to parallel tumor burden. It has been increasingly shown to help with prognostication in breast, colon, and skin cancer, as well as neuroendocrine tumors. Several studies have examined the use of liquid biopsy in the prognostication of neuroendocrine tumors. 2 studies in 2013 and 2015 show that the presence of at least one CTC was associated with worse progression-free survival and overall survival in patients with neuroendocrine tumors. Our group sought to determine whether liquid biopsy can be used to prognosticate parathyroid cancer. We designed a pilot study to evaluate the role of CTCs in patients found with parathyroid cancer identified on final pathology. As a tertiary referral center, patients with parathyroid cancer are frequently referred to our institution with local regional recurrence or distant metastasis several months to years after initial diagnosis, making it difficult to assess the ability of CTCs to predict disease recurrence from a quiescent state. We recruited 21 patients into the study at this time. At first collection, at least one CTC was detected in 38% of patients in the whole cohort, 27% of patients with no evidence of radiographic or biochemical disease, and 50% of patients with local regional or metastatic disease. This demonstrates a higher likelihood of finding detectable CTCs in patients with local regional or metastatic disease. Over a median follow-up of 6 months, the rate of detection of CTCs increased to 52%, with more patients in the metastatic group with detectable CTCs. Over the current study period of 18 months, radiographic and biochemical follow-up was obtained for 57% of patients. Patients with at least one CTC have a median progression-free survival of 9.8 months compared to 16 months in those without CTCs on Kaplan-Meier analysis, with a trend towards statistical significance, which shows preliminary evidence for the ability of CTCs to predict progression-free survival in patients with parathyroid cancer. While the data support the potential for the presence of CTCs to prognosticate disease, further follow-up is required both in number of patients and time. In addition to CTCs, ctDNA offers a useful tool for prognostication of cancer. While CTCs may predict disease progression, there were some instances in which patients had detectable CTCs but no evidence of progression thus far. Could the addition of ctDNA analysis to CTC assessment help refine results, especially in those patients with metastatic disease? In our cohort of 21 patients, we obtained ctDNA samples of 6 patients at different stages of disease. ctDNA analysis showed a correlation between disease status and ctDNA level. Patients with no evidence of disease had the lowest ctDNA level, while patients with distant metastasis had the highest. Furthermore, of the 3 patients with local regional disease or distant metastases that had no CTCs detected, they all had ctDNA levels greater than 5 nanograms per ml. Combining these data would help rule in these false negatives on CTC analysis. While this preliminary data shows that CTCs and ctDNA may be used to prognosticate parathyroid cancer, further follow-up is necessary to see whether these represent significant findings. In summary, parathyroid carcinoma is a rare disease that is diagnosed after surgical intervention. The most common hereditary syndrome associated with parathyroid carcinoma is HPT-JT, with an overall incidence of 15%. Treatment of advanced parathyroid carcinoma requires multidisciplinary input and a combination of anti-resorptive and targeted therapies. Liquid biopsy may serve as the next tool to help prognosticate this rare tumor and guide both surveillance and treatment. First and foremost, I would like to thank our patients. They have entrusted us with the care of this complex disease, and we are forever grateful. Thank you to the friends of JJ who helped this spirit of this work continue. Thank you for the guidance and mentorship of Dr. Nancy Perrier, who has led the research on parathyroid carcinoma at MD Anderson. With the help of many colleagues and friends who have spent hundreds of hours to make this happen, we have transformed our understanding of parathyroid cancer. Finally, thank you for the opportunity to discuss this important and relevant topic at this global webinar on endocrinology and diabetes. Please feel free to reach out with any questions. Thank you.